So welcome everyone to tonight's webinar with Adelaide PHN in conjunction with the Department for Health and Wellbeing, SA Health and Southern Adelaide Local Health Network. And we're delighted tonight to be providing part one of the long COVID update series, and very grateful for all of our presenters here who are joining us this evening. Before we do commence, I would like to acknowledge the land in which we're meeting here today and pay our respects to elders past, present and emerging. Before we do start, however, with our long COVID update today, I would like to just provide a very brief COVID update because we have been getting a lot of questions through to our GP liaison email address. We've been getting a lot of personal calls, texts, emails through around the changes to isolation. What are the requirements now in general practice? I'm just going to very quickly over the next couple of minutes just go through some of those critical changes that did come into effect last Friday before we do hand over to our fabulous panelists this evening. So we do have Dr. Eve Bailey with us, who is leading our long COVID work in the department as our GP liaison lead for long COVID, and it's fabulous having Eve in the team. We've got Dr. Kasani Manuel, who's here with us today, and many will know her in her excellent role in rehab medicine, and particularly her role down at Flinders Medical Centre. So we're very pleased that we've got her here this evening. And then we have on our other screen as well, we have the team also from SALN as well, and particularly the long COVID allied health professionals being represented here today. And we've got Matt with us here. We've also got Sarah as well. And then we have in the back, we've got their Jack as well, just at the front there. So fabulous to have everyone with us this evening as we talk through long COVID. So as I said, I'll just run through a couple of quick updates on COVID management and some of the new changes that did come into effect before we move across into long COVID. For everyone's awareness, we have now changed the web page for referral for the National Medical Stockpile antivirals. Now, there was some technical reasons that has now moved. So for everyone's awareness, if you are referring a patient in who is not eligible under the PBS for antivirals, or you are referring them in for a remdesivir infusion, then please use the referral form online. That goes directly to the local health network. So important to know that that form has changed. So if you had a previous bookmark site, you may need to just update that, and we have included that link in today's update, and we'll also have that going into our GP update as well. So it's still clicking through the same way through access and referrals. We've got the guidelines and resources as well available. And you'll note that bottom box, the pre-exposure prophylaxis as well. Some of you may be aware that Evershield was put forward to be listed for being able to be utilised under the PBS through general practice or through other sites. Now, that was not approved at the most recent meeting, whereby everyone came together through PBAC. So what that now means is we are still going to be administering those injections through our priority care centres, and we were previously doing this through the Marion site. That's now stopped, but we still have Hindmarsh available and McIntyre as well, where those prophylactic exposure injections can be given. So please, referring patients through, we'd love to encourage that to continue occurring. There's still ongoing review around the evidence around the dosing, and particularly whether 2 doses are needed, and so that's why there was there was not a progression at this point in time for listing that under the PBS. So hence why it's still under the National Medicine Stockpile and needs to be managed through by SA Health. Just in terms of antiviral access, we've also got the criteria as well for the PBS, just as a reminder as well. And we're expecting that there will be some changes coming up very soon around criteria changes, and particularly moving to only one risk factor. So expecting to see that there'll be an increase in uptake now of oral antivirals. But I will say South Australia is continuing to lead. We are still getting the highest rate of PBS scripts for antivirals. So well done, and particularly doing really well in Paxlovid as well. So this is just a reminder again about the treatment referral online. Now, to mention as well, from the 1st of November in the doctor's bag, we will have Molnupiravir and Paxlovid as well available, which is fabulous news. So please keep that in mind. We'll be putting out more details soon, but really great, particularly for our regional and rural GPs to have access to these medications available, ready to be dispensed, and they're not relying on a delay, particularly after hours or on weekends. Just a quick update on genomics, as we always just like to just touch base on where we're currently sitting here in the state. And this is the latest data that's come through today. So really grateful. Thank you to SA Pathology for this. We are still seeing the predominant being BA5 as being the predominant variant that we are seeing here still in South Australia, and that's consistent with what we are seeing overseas as well. Always find that this is quite useful to see where we've seen that progression through BA1, BA2. We had that very short burst of BA4, then predominantly now sitting in the BA5. And you'll note as well that, of course, with there's some additional areas, co-infections now been added onto this as well, but still sitting very much predominantly in the BA5. It is important if people are international travellers or that they're healthcare workers, absolutely, or someone who is in ICU, then important to be looking at our genomics, and we are still undertaking genomics on those PCR samples for those higher risk individuals here in SA. Finally, I just want to mention about the Moderna bivalent vaccine is now available across most of our sites now for individuals aged over 18, and particularly important for individuals who haven't had the 4th dose, so encouraging uptake. We are expecting that there'll be data in, and we just had an update this afternoon from the TGA that we're expecting the data will be in before Christmas on some of the efficacy data around the Moderna bivalent, I think, which will be really interesting, particularly as we know some people have been holding off, and then we've likely got Pfizer coming in the first quarter of next year with that specific Omicron vaccine as well. So it will be interesting to see, but not seeing a huge uptake currently across the sites for this vaccine. But again, reminder, we are still expecting we're going to have that next wave of cases around that end of October time. So that's only a couple of weeks. So if people haven't, or if you haven't had your 4th dose, please consider having that so that you do have that maximum coverage to reduce down your severity of illness. And final point I will just talk about is the isolation changes, and particularly around those changes that did come in last week. So those were the changes where we have now removed all mask mandates, and that's shifting to a policy-based decision. So policy-based for public and private hospitals. We do still have requirements in around aged care that's still sitting in place. But again, a reminder for general practice, it does shift now to a policy-based decision. The removal of all close contact requirements and the removal of vaccine mandates, and these were for the phase 2 and 3 healthcare sites, which does include general practice as well. But again, comes back to a policy decision around where you decide to set your policy within your practice. We do still have mask mandates, and we are working through the next phase now of vaccine requirements in hospitals. The consultation period is now finished around the updated vaccine policy for SA Health staff, and then that will transition to a policy-based decision. We do know that there is a lot of concern currently around screening patients, particularly in general practice, patients coming in not wearing masks. You know, how do we protect our most vulnerable in the community? And we do know that many practices are still keeping in place a policy position around wearing masks, utilising an occupational health and safety basis for that policy. So, and that's absolutely reasonable as well. I'm looking forward to meeting with the AMA next week, and we'll have a further discussion around some of the impacts on private medical practice as well. And finally, particularly around public health advice around having staff coming in who are COVID positive or for close contacts. Again, our very strong advice is that you have a policy position in place that staff do not come to work for 7 days if they are COVID positive. And again, if they are a close contact as well, implementing in a testing regime as well if staff are going to come back as close contacts wearing appropriate PPE. So we're very happy to take questions, and particularly for questions to be posted in the Q&A box, and we'll answer those as we progress this evening. But I want to get back to why we're all here, which is around the long COVID update and advice. And finally, just a reminder about our telephone number, 7 days a week, 8 a.m. to 8 p.m. We are here to answer all your COVID questions, and also supporting patients that you have in the community who may need access to antivirals, a face-to-face visit, or really not sure around where you can escalate care. We have the GP respiratory clinics, and they can see patients face-to-face. The site at Kilkenny, and they've done an amazing job. That site did close yesterday, but we still have the 10 remaining sites across SA, and there is really good capacity across these sites. So please encouraging your patients to book into a GP respiratory clinic. I looked earlier today, there were lots of appointments, for instance, at the Parkside one, very easy to book online. So please encourage your patients or your staff, if they need an assessment, to book into one of those sites. And that's all from me. So I'm going to hand over now to Dr. Eve Bailey, who will start us through this journey around long COVID, part 1 series of today. Thank you.
Thanks, Emily. So welcome everyone. Great to see so many people online tonight, and we're very excited to have everyone here. So we've got a two-part series on long COVID, and tonight's presentation, we're kindly joined by Salin, and I think first up we're going to cross over to Dr. Kasani Manuel. So she's a rehab consultant working at the post-COVID-19 clinic at Salin, and she's going to talk us through how the clinic's going and what they're busy doing over there for all of our patients. So over to you, Kasani. Thank you so much.
Perfect. But you're on mute.
Okay, second button I had to click. All right, all good. You can hear me now.
Yes, terrific.
So today we're going to be talking about our post-COVID clinic that we called the Post-Acute Sequelae of COVID Clinic here at Flinders Medical Centre. My name's Kasani. I'm one of the rehab consultants, and we're lucky to have three of our allied health members here who are treating patients with long COVID. So Jack Davidson, our exercise physiologist, Matt Labasso, our physiotherapist, and Sarah Clapper, occupational therapist. So we are servicing the Southern Adelaide Health Network. There is also a clinic opening the central area, but not one yet in the north area. So the central are seeing the patients from the north at the moment. So I will be talking about our experience here primarily. So our outline really is that I'll start talking about this clinic, and then you'll hear from each of the therapists about what they're doing. So first, we're just starting with some definitions. So we named our clinic the PASC clinic, which is the second definition there on the slide, because that's what was in favour when we opened it. And we started seeing patients from the 4-week mark after their COVID infection. We've now moved to really embrace the World Health Organization definition, and that's from 3 months. So now our inclusion criteria is that the patient needs to be 3 months following their acute infection or presumed acute infection. So the WHO or World Health Organization definition is post-COVID condition occurs in individuals with a history of probable or confirmed COVID infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by alternative diagnoses. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, but also others, and generally have an impact on everyday functioning. Symptoms may be new in onset since the initial recovery from an acute COVID infection or persist after the initial illness, and symptoms can fluctuate and relapse over time. Patients, just that umbrella down the bottom, people often talk about the umbrella of different terms, but patients really are calling themselves long COVID. I think that's the favoured term for patients themselves, but in the literature and in different clinics and in different places, you'll hear different terms used. So I just wanted to point you to this resource. It's the Clinical Management of COVID-19 Living Guideline, and it's on the web, available from the World Health Organization, recently updated, and it's now its 5th version. It's got guidelines about acute management, but also does have a section about the post-COVID condition and management guidelines around that. So our clinic basically started quite early this year. We developed the clinic based on advice from other states, because they'd seen COVID earlier than us, so particularly Sydney and St Vincent's Hospital there, and also Victoria. And we also spoke to the UK quite a bit too, trying to develop what we needed to do to prepare for what we could see was coming. We collaborated with respiratory medicine, who are happy to be involved, and we got together a team which involved a rehab consultant, a respiratory medicine registrar, psychiatrist, physio, nurse and pharmacist. And we commenced the clinic in March, the start of March, thinking we'd do a monthly clinic. But by the middle of March, we decided we need to go to fortnightly, and then a week later decided it really needs to go to weekly because of the referrals that were coming in. We still have an issue with funding at the moment because the clinic is unfunded. So we're hoping that we will get funding at some point and we'll be able to bolster the clinic up a bit. Our inclusion criteria is basically that someone needs to have had the infection, or we assume have had the infection, so symptoms in keeping with it, 12 weeks prior at least, and one or more of the following, usually it's more. So new and unexplained shortness of breath, cough, musculoskeletal or organ pain, fatigue, neurological symptoms, and psychological and mental health condition. And I think a lot of these things can be managed in primary care and by the GPs. And what we think might need to be referred to us are those more complex patients, so people with quite a complex or severe disability or limitation to their function, or someone with a diagnostic dilemma, and perhaps those are the patients that you consider referring to us. Our exclusion criteria is really a risk assessment, so we don't want patients referred in that need to be, that have a potentially life-threatening or serious illness or condition that should be seen prior. Just so I give you an idea of how we run the clinic. So a patient, we'll first have a team huddle and discuss the patients we're seeing that day. And then say following patient that's orange, patient 1, they'll see a nurse for half an hour, a physio for a half-hour slot, and then one of the doctors, and it'll be either respiratory or rehab, and we decide based on their primary symptoms, and that's an hour. So the patient's in here for 2 hours. We do have a psychiatrist as well on the clinic, and they'll see 2 patients for an hour and a half, up to an hour and a half each, though they're only referred to internally. So the patient needs to come first as a new patient and go through the nurse, physio, myself, or the respiratory doctor first, and then we decide who to refer on to the psychiatrist. So not direct GP referrals into the psychiatrist at this stage. We then have a team huddle at the end of the clinic, and that's really beneficial, I think, because we all discuss, and with the occupational therapist, the physio, the psychiatrist attends, both of the doctors, and we discuss each patient and what we think the best plan going ahead is. This is a wrap up of what we do. So basically we'll receive a referral and the nurse will do a screening phone call to the patient, checking their eligibility for the clinic, but also it helps us to get more information to be able to triage the patient appropriately. We send out a whole heap of assessments so that the patient completes it in their own time prior to the appointment. And those are the assessments that we currently get them to do. So we've got the Yorkshire Rehab Screening Tool, and that was the first validated method, questionnaire, self-reported measure for patients to do on long COVID symptoms. So that's why we started with that one. We've got a fatigue scale, quality of life scale, depression, anxiety, a dyspnea scale. And then a month or 2 ago, we added in the Epworth-Sleepiness scale, as we felt we were seeing a fair bit of undiagnosed sleep apnea, and that would be helpful. So they do all that prior to the appointment so that they can do it in their own time. They can have a bit more of a think. A lot of people are fatigued, so trying to add it on to a 2-hour appointment we thought wouldn't work very well. We then, when the patient comes into the clinic, they start with the nursing assessment or physio assessment, depending on their schedule. The nursing assessment involves vital signs, including postural, blood pressure and heart rate, a weight, and we also ask them their pre-COVID weight. Sorry, my light turned off. Cognitive testing where indicated, and also where indicated this NASA 10-minute lean test. So this is a test that's there to identify orthostatic intolerance. And we are seeing that in our post-COVID patients, not all of them. Some of them are having orthostatic symptoms. And you'll hear more about that from Professor Lau, who will do the second webinar on that and autonomic dysfunction. But this test is like a tilt test, except you don't need the equipment. And it's 2 minutes of the patient laying down and resting, and we take their blood pressure and heart rate, and then 10 minutes of them relaxed, leaning against a wall and getting their heart rate and blood pressure over that time, looking for symptoms and also looking for an abnormal heart rate response. During the physio assessment, the physio gets quite a detailed exercise history. and also does these measures of a 6-minute walk test, a 1-minute sit to stand test, and a hand grip strength. Also a lot of education in that session and providing some written resources and links. And then they come to see myself or the other doctor for the medical assessment. So by the time I see them, I've got quite a bit of information already to help start the consult. And then the post-clinic huddle that we talked about. So just briefly on measurements. So I showed you the ones we're doing at the moment, but we're constantly evaluating which ones are helpful and which ones aren't. You know, these are important for us to try and track the patient's journeys, to try and understand long COVID, because it's still a very new condition, and also over time to understand the effectiveness of management, but also to be able to compare results from interstate, overseas, other clinics with ours. The PCCOS is the post-COVID core outcome set, and it's a group of international doctors, researchers, patients, their carers, who come together to try and determine which measures are most useful. The most recent meeting was just 3 weeks ago, and they came out with these instruments that they feel are very useful. So we haven't been doing the recovery scale, but we'll start it from next week. We already do the modified MRC dyspnea scale. And then these are the other ones that they said were useful. We do some, we don't do all of them, that's a lot. So you need to pick and choose based on the patient which ones are relevant. I just thought it's good for you in general practice to know what those measures are. So talking about our clinic, what we did was we started by screening patients that had COVID. So the patients that were admitted to Flinders either with COVID or who got COVID as a complication of their admission, we then screened them via phone call at 4 weeks afterwards. So this was early this year. And at that time, we found that 33% were reporting some ongoing symptoms, and we booked about 4% for the clinic. We then did a screen at 12 weeks, and we had about 17 reporting ongoing symptoms, but most of them saying they were mild and they didn't think they needed to come in. We booked about 2% of them. So we stopped screening at that point because we're getting quite low numbers, but it just gave us a bit of a feel because COVID was really very new to us as to what the volume might be. So fairly low from those, whereas if you look at the World Health Organization, they're saying 10 to 20% have ongoing symptoms. But do they actually need to be seen in a tertiary centre? I think that's one of the main differences. So currently the clinic has seen, we've had 160 referrals that have been reviewed and accepted. Initially our waiting list was very good and people were getting within a few weeks, and unfortunately it's blown out a bit to around at the moment I think it's around 4 or 5 months, which isn't ideal because I do think the patients getting referred do need to be managed faster than that, but again hopefully with increased resources we'll be able to see people a bit quicker. So we've seen 126 patients so far. At the moment the age range is huge, so 18 to 90, and our mean age is 48 years, so very much this working adult, family responsibilities, that kind of picture. Seeing more females than males, which fits with existing literature on this. And yeah, most of them were in paid employment prior to COVID, so around that 70%, with 5% as students, 7 unemployed, and some retired. So to us, looking at things like employment impact is important. So this comes from that Yorkshire screening tool that we use, and we've looked at who's said yes and no to that question of, is there a change in the duration or hours of working as compared to before the acute illness of COVID? And this was just from data from 105 patients, and from that we've got 43 or around 40% of people saying yes, there has been change. And for those who said yes, we've got most of them needing to decrease their hours and some of them needing to stop work altogether. So it's fairly significant. On a personal level, these people have gone through huge change, but also on a societal level, this could be a big problem with our workforce. Common symptoms. So I did this table back when we'd only seen 40 patients, but I think the picture is very similar. So fatigue is by far the most common symptom we're seeing. Breathlessness or dyspnea is up there. sleep issues and cognitive changes, depression and pain. So as fatigue is so common, some of the questions we've got here answered. So this was 108 patients. We've got 103 saying, yes, they're more fatigued than before their COVID illness. And then looking at their self-reported level of fatigue and comparing it pre-COVID to what they are thinking now on initial assessment. So they're thinking before COVID, they were around the 0, so that's no fatigue present at all, or very mild, the 1s and 2s. And now on initial assessment, when they come in, they're up more around the 8s, 7 to 10. So 10 is classified as severe fatigue and life disturbing. The patterns of long COVID that we either see someone get an infection and then get gradually better, but it just takes so long, and they're not expecting it. It would take that long to recover. The other main trajectory seems to be that they recover from the acute infection, and then they either the symptoms don't quite go away and start getting worse, or they completely go and they come back and they get worse over time. We don't know where that curve goes to. I found this article quite interesting and useful. So the patients that we're seeing here, they're not all the same. They've got a variety of symptoms, and trying to work out why this is. This article is quite a helpful narrative review where they've tried to classify the different types of long COVID symptoms into different groups. And they divide it into this multi-organ sequelae. And that's where they say, look, it was a respiratory illness primarily, but it can affect other extrapulmonary organ systems, and that can result in subclinical dysfunction, and that might account for some of the symptoms. There's also more of a chronic fatigue group, and this is very much associated, similar to the myalgic encephalomyelitis, the chronic fatigue syndromes that we've seen with other post-infectious fatigue type syndromes. And some patients do go on from long COVID to fit that criteria of diagnosis for the ME and CFS. Pulmonary fibrosis sequelae, so altered lung function, sometimes abnormalities on radiology and pulmonary function tests. And then we've got the orthostatic syndromes that you'll hear about more in the next webinar, but it's postural orthostatic tachycardia that we think is related to a possible dysautonomia. There's a post-intensive care syndrome group, so the patients who were very unwell in intensive care who then get cognitive or mental or physical symptoms longer term. And then the group that they think is more of a medical clinical sequelae of chronic health conditions that may not have been diagnosed. It's like they're unmasked. So the exacerbation of those health symptoms and chronic conditions, and that might be because they've not managed the condition as well over the COVID period, or the COVID itself has exacerbated them, or they haven't been diagnosed. We've heard about a lack of sort of routine visits and checkups, and therefore a deterioration in health of survivors of COVID. I'm not going to talk very much on potential mechanisms because the topic is just ginormous. But this article is quite helpful. It's a systematic review. It was published in March this year, and it's combined 98 different research articles in it about papers published that are discussing and researching mechanisms underlying this long COVID. And the paper breaks it up into this neurocognitive, psychiatric, chronic fatigue, pain symptoms, and the cardiovascular pulmonary symptoms that we can see. And I guess just to briefly try and summarize, there are a number of different hypotheses or theories out there, and one of them is that there's tissue damage from the acute infection, and that might be nervous system damage as well. Another goes along the lines of there being a lingering virus or viral antigens. Another that a lot of patients will mention is this idea of microclots from inflamed blood vessels and endothelial cell dysfunction. I mean, that's the other thing. A lot of these patients have done a lot of research and they know what's out there to some extent. Another is along the inflammatory state, and there's a number of different branches of this idea of the inflammatory, unresolved systemic inflammation with cytokine storms or mast cell activation syndrome or T cell dysfunction. The role of ACE2 receptors in this process, and then also mitochondrial dysfunction. And we don't have the answer. It might be that there isn't one answer, but rather there's a number of things going on that could lead to these different symptoms. I'm going to wrap it up there, and I'm going to hand over to Jack, who'll talk a little bit more about some of the potential mechanisms and pathophysiology. So I'm going to stop sharing my slide.
Just double check.
Hi everybody, hopefully you can all hear me okay.
Perfect, thanks.
Excellent. So I'm Jack, I'm an exercise physiologist here, primarily working in the day rehab service. I'm seeing long COVID patients after they've been through the COVID clinic and then referred down to day rehab. I've got, let's get to my next slide. So just a couple of points that we're going to touch on. So just as an allied health group, I've probably got the driest of topics in pathophysiology, and then hopefully Matt and Sarah can jazz it up at the end with some practical applications of how we go about a therapy and that type of thing. Very quickly, in terms of incidence and prevalence, so unfortunately the incidence rates vary greatly from study to study. In part, that's due to the definitions from previous slides, but also due to the way in which the data has been collected and analysed in the literature. But as Kasani said, as per the World Health Organization, it's estimated that 10 to 20% of those that contract COVID-19 will develop symptoms associated with long COVID. When I did a previous presentation on this topic last year, I found a report by the Zoe COVID symptoms study from the UK, and that reported a lower risk of developing long COVID in those that were double vaccinated. However, I'm yet to revisit this particular variable when 1 year on, excuse me. So I'd be interested to see what the recent data is on this. I'll just very briefly touch on pathophysiology from the acute stage, but I'm aware that the audience probably has a good understanding of pathophysiology of initial infection and acute disease, but we just thought it might be important to touch on briefly. So we know that COVID-19 is spread via very small, fine droplets and aerosol particles that contain the virus. The virus enters the body via the upper respiratory tract and then can progress down to the lower respiratory tract and into alveoli, especially in moderate and severe disease. And there is also a case to be made in the literature for the virus entering the brain via the olfactory nerve. So the spike protein on the virus will bind to ACE2 receptors, which are expressed in a variety of tissues throughout the body. So in the case of the alveoli, ACE2 receptors are present on type 2 alveolar cells. So once inside the cells, the virus can replicate and burst back into the alveoli, triggering an inflammatory response, or sometimes called a cytokine storm. So this intense inflammatory response, both within the alveoli and alveoli wall, will inhibit gas exchange and increase fluid in the airspace. Additionally, the type 2 alveolar cells, which are responsible for surfactant production, will fail, and then the alveoli might collapse in on itself. So this can result in acute respiratory distress syndrome, and this is deemed a life-threatening issue. As the virus passes into the bloodstream from that point, it can travel throughout the body and infiltrate other organs and systems via the ACE2 receptor, which, as you can see in the figure on the right, is expressed throughout the body, accounting for the variety of symptoms associated with this disease. So the heart in particular is one of the organs with the highest expression of ACE2 receptors. In the event a patient has moderate or severe disease with a sustained inflammatory response or thrombophilia, The results can be devastating on various systems, resulting in either fibrotic changes to lung tissue or cerebrovascular pathology, such as stroke or cardiac disease. So with regards to cardiac tissue, one study outlined both the microembolic damage of the disease, but also the structural change to the tissue as a result. So that would impair contractility, conduction, and valve function. So the point of going through this content is to illustrate that some symptoms associated with long COVID may be due to the severity of the disease in the acute phase. And that comes back to those 6 phenotypes that Kasani was just speaking about before. So in terms of typical symptoms reported in this cohort, fatigue is overwhelmingly the most commonly experienced, as Kasani pointed out. This is a figure taken from a review by Lopez, Leon and colleagues from last year. And I think it's a good graphic to show the variety of symptoms experienced by long COVID sufferers. So fatigue being the most common, followed by cognitive dysfunction or brain fog, post-exertional malaise, which I'll come to in a moment, headache, disordered sleep, depression and anxiety. So these symptoms can be variable in severity and in persistence. So in contrast to the points I addressed in the previous slide regarding acute disease, many of these symptoms can be seen in patients independent of the severity of the initial disease. As Kasani pointed out in a previous slide, we can often have patients that responded well to their initial infection and experience very mild symptoms, but then go on to develop very significant symptoms months after their initial infection. So as I said, later in this presentation, my colleagues will discuss current approaches to treating these issues. But for now, I'll just touch on the potential pathophysiological mechanisms responsible for these issues and hone in on just 2 of the most common symptoms. So getting a grasp on the various potential pathophysiological mechanisms of long COVID for this presentation was very tricky, as Kasani kind of mentioned before, given the highly variable clinical spectrum and broad impacts it has on various body systems. However, there were a number of reviews in the literature that neatly summarized a number of theories that are out there, one of them being this one, a systematic review by Castanaro Sapatero, which Kasani also pointed out. I think I've been reading the same stuff. It's from May 2021, and it collated many of the potential mechanisms. I can appreciate that maybe the table might be a bit small on this slide, but the point I'm trying to illustrate is that there are a number of potential mechanisms responsible across multiple body systems. But as you might be able to see, they were able to break them down into various categories. Just before I move on, I think if we were to go through every potential mechanism in detail, we'd be here for hours. And I'm sure there are people better placed than I to go through them in detail. If you are interested in a deeper dive into the pathophys, I found these free webinars pretty helpful. They're broadcast monthly. They are backed by a number of universities in the US, as well as Project ECHO and the CDC. So yeah, I'd highly recommend those if you want to get stuck into the pathophys. So for the remainder of my time, though, I'll focus on just 2 of the common symptoms and potential mechanisms associated with those. So the first one is fatigue. So the number 1 symptom experienced by patients with long COVID. It could be described as an unrelenting exhaustion that impacts on all aspects of daily living, significantly impacting a person's quality of life, and could be considered similar to that of post-stroke fatigue or cancer-related fatigue. Some of the potential mechanisms for fatigue that have been posed in the literature are listed here. It's unlikely that there is one sole mechanism for fatigue, but rather a range of central, peripheral, and psychological factors that contribute. And it's likely that multiple systems are involved, so including neurological, cardiovascular, metabolic, immune, and musculoskeletal. So neuroinflammation is likely one mechanism, a process triggered by activation of microglia, and something that is brought up frequently in the literature. This could also account for a broad range of neurocognitive and mental health disorders. Some published articles referred to persistent vascular inflammation and thrombophilia, believing that microembolisms may play a role in compromise of various tissues, including the nervous and muscular systems. Hypometabolism in the frontal lobe and cerebellum has also been implicated in COVID-19 patients with fatigue. And it's likely caused by systemic inflammation and cell-mediated immune mechanisms rather than direct viral neural invasion. Then we have muscle mitochondrial dysfunction. So there is a hypothesis that there could be a bioenergetic disorder in muscles due to mitochondria dysfunction, particularly with respect to the Krebs or citric acid cycle. In lay terms, accessing this energy or accessing energy via this normally very reliable system becomes impaired. But I'll come back to that particular dysfunction in a couple of slides' time. And then finally, CSF congestion. A narrative review explained that congestion of the glymphatic system may play a role. It's believed that there could be a buildup of toxins within the central nervous system due to resistance of CSF drainage, subsequently contributing to fatigue. So post-exertional malaise or post-exertional symptom exacerbation is a feature of the inability to produce sufficient energy on demand. And it's characteristic amongst those with myalgic encephalomyelitis and chronic fatigue syndrome. It can be a debilitating cluster of symptoms that is experienced after a stress or exertion. So the severity and timescale is very specific to the individual and can include a number of subsymptoms, including disabling fatigue or exhaustion, cognitive dysfunction or brain fog, pain, headache, breathlessness, heart palpitations, fever, sleep disturbance, exercise intolerance, or gastrointestinal issues. It's often referred to by patients as a crash or a relapse or a collapse following some form of exertion. Triggers are most commonly physical or cognitive, but they can also be social, emotional, orthostatic, or sensory. And it can trigger worsening of known symptoms or bring on new symptoms. The symptoms can occur immediately after exertion or have a delayed onset of up to 24 to 72 hours. Unfortunately, in some of the patients that I've seen, the longer the delay in symptom development, the more difficult it is to attribute to a specific activity or event. Unfortunately, in the case that someone experiences post-exertional malaise, it can take days, weeks, or even months for patients to recover, and it can really set back their recovery. So for this reason, we really try and discourage triggering post-exertional malaise. So if we're looking at the potential mechanisms for post-exertional malaise, we first need to look at our energy systems. So there are generally 3 or 4 energy systems, but for the purpose of the talk today, it's best to divide them into aerobic and anaerobic. So anaerobic obviously does not require oxygen. It's got a quick turnaround time in terms of energy production, which is great for certain physical activities that require short, quick bursts of energy. Unfortunately, this system has byproducts of lactate and metabolites, which may contribute to fatigue and cause muscle pain. Conversely, we have the aerobic system, which is a bit slower but more sustainable. Byproducts of aerobic energy production are carbon dioxide and water. And we rarely ever operate solely under one energy system. It's usually some contribution from all of them. So with regards to post-exertional malaise, a lot of the literature points at similarities between long COVID, myalgic encephalomyelitis, and chronic fatigue syndrome. So the figure on the screen here is from a paper on ME from 2015, but it highlights the role of impaired mitochondria in post-exertional malaise. So a very quick reminder on the role of mitochondria. It's the powerhouse of most cells, and it's responsible for generating energy in the form of ATP. So in the event that mitochondria is impaired, it cannot produce sufficient energy via its normal processes. So it's therefore thought that the body quickly transitions into an alternative energy system, that being anaerobic, which is usually reserved for more immediate short bouts of physical exertion. So this means patients become more reliant on an energy system that's not designed to support habitual or long-term movement, such as walking and those low-intensity household chores, those types of things. So this is likely to contribute to major energy deficits and result in fatigue. So just in summary, broadly, it is thought that there are two overarching things going on in long COVID. So the first being a virus-driven cellular alteration related to its tendency to attack the nervous system. And that's been suggested to possibly contribute to the pathophys of long COVID. This mechanism could account for olfactive disorders or manifestations related to autonomous nervous system dysfunction. So that's something I haven't touched on today, but I believe Professor Lau might do that next time out. And then secondly, a dysregulated immune reaction in response to either initial infection or ongoing viral persistence is thought to possibly provoke autoimmune manifestations, coagulation and fibrosis pathway activation, or metabolic disturbances. As previously mentioned by Kasani, the narrative review conducted by Yong in May last year proposed 6 distinct phenotypes that you can see on the screen there, and I won't go through again. And just finally, I think the following line from the Castanera-Zapatero paper summarizes this topic well, and that is the clinical picture of long COVID could presumably not be ascribed to a single pathophysiological mechanism, and that responsible mechanisms were probably numerous and intertwined. I'll just pass on to my colleague, Matt.
Beautiful, thank you. So now we're just going to speak on a little bit more on fatigue and fatigue in the context of exercise. So I just wanted to start off by showing you some of the recent guidelines that Kasani had in her slides. This is from the Living Guidelines for Clinical Management of COVID-19, which is just came out in September, and what it does, it identifies that using education, skills training on energy conservation techniques such as pacing, and in the absence of post-exertional symptom exacerbation, a cautious return to symptom titrated physical exercise training in the management of fatigue. So what that's saying is essentially, with that cautious approach, in the absence of post-exertional symptom exacerbation, they are recommending that physical exercise training can be used in the management of fatigue. It's worth noting that in these recommendations, they repeatedly state in the absence of post-exertional symptom exacerbation across a lot of recommendations. These guidelines also recommend physical exercise training for arthralgia, breathing impairment, anxiety and depression, and orthostatic intolerance. So the next few slides are just touching on a few pieces of literature with reference to exercising in long COVID, but also how management approaches may be usable from other similar conditions such as ME/CFS. So on that note, this narrative review suggests that in the absence of high quality evidence on post-exertional symptoms in long COVID, the principles established for managing post-exertional symptom exacerbation in CFS and ME could be adopted for long COVID. So that's something to think about when managing long COVID going forward. So this cohort study shows results similar to other studies out there in which a pulmonary rehab program or an adapted pulmonary rehab model with pacing advice has shown significant improvements in physical function and reducing fatigue. And again, they comment on how there are parallels and similarities with the management of ME/CFS. So this randomized controlled trial is one of the best and most recent I could find. It aimed to compare the outcomes of patients with long COVID undergoing a supervised therapeutic exercise intervention and comparing that with a self-management approach using the World Health Organization self-management leaflet or handout. And that's interesting because we actually, in the long COVID clinic or post-COVID clinic, we do point them towards that handout. So just to break down this study, it was an individually tailored multi-component exercise program that went for 8 weeks. So they had 2 sessions of moderate intensity resistance combined with aerobic training, and then a 3rd day of light intensity continuous training. The results showed improvements globally between both groups, which was good to see. However, the supervised exercise intervention showed significantly better quality of life, less fatigue, less depression, increased functional status, and more increases in muscle strength and cardiovascular fitness. The interesting thing about this randomized control trial as well is they also specifically acknowledged post-exertional symptom exacerbation. And they commented that due to the fact that the patients were treated individually and the intensity of each session could be adjusted, they had no patient dropout due to tolerance issues, and they reported no adverse events. And just lastly, given the recent literature that I just showed you with suggestions that there's similarities between ME/CFS and long COVID, I thought this systematic review would be relevant, and it's looking at 8 studies that looked at exercise therapy in the treatment or in chronic fatigue syndrome. And it showed essentially that 7 of the 8 studies showed a reduction in fatigue following exercise therapy. The exercise therapy was aerobic training ranging from 12 to 26 weeks. But then that's just further supporting the use of potential role of exercise in this condition. So given the current clinical management guidelines that are out there and what we know about post-exertional symptom exacerbation, there are a few core considerations for returning to exercise. And this is assuming that they've had a full medical workup and nothing too serious has been identified. So firstly, there's just an education component. So just making sure that they know what you're talking about. They know what post-exertional symptom exacerbation is, and that you've done, an in-depth assessment and where applicable, a multi-D assessment. We want to assist patients in establishing a baseline of exercise, but ideally with not just exercise, with everything. We want to set a baseline for an amount of activity that's not going to be exacerbating symptoms. So we want to strip things back and find a baseline where they're not having these ups and downs, they're not having these crashes. We don't want to be contributing to what's called the boom-bust cycle, and I'll talk about that in the next slide. Exercise should be self-paced rather than imposed by the clinician, just in order to prevent post-exertional malaise. So we don't necessarily want to be pushing them and telling them exactly what to do. We want them to be able to pace themselves and have the skills to be able to do that. Exercise should be conservative, cautious, low intensity, and it should have a symptom titrated approach. Light aerobic training is probably a good start, and we can use RPE scales, so rate of perceived exertion scales, to help them measure the intensity of whatever they're doing and to avoid overexertion. And just down the bottom of that slide, stop, rest, and pace we need to consider that, absolutely, especially with exercise. So this is the boom-bust cycle. You may or may not have heard it with chronic fatigue syndrome, but essentially it's this idea of they feel good, they have a good day, they do a bit too much on that day because they feel great, and then they crash. And as Jack spoke about, this crash may not necessarily happen on the day or even the next day, but it can happen 3 days later. So it makes it really hard to know to judge what you're doing and what's actually contributing to these crashes. And as you can see in the graph the issue with this boom bust cycle is over time of these good days, bad days, they're actually quite often not actually improving at all, or they're even getting worse. So we want to avoid this at all costs, and particularly when thinking about exercise, we don't want to be contributing to any of these crashes and fitting into this pattern. So these are two approaches that are in the literature at the moment, and they suggest, so these were developed for management and return to physical activity post-acute COVID. So it's important to note that, but they suggest a phased or a graded return to physical activity. So I actually use the Salmon et al. Returning to physical activity table in the post-COVID clinic. But given that it is from the acute, it's developed for the acute phase, I have that context. I've had those discussions about, okay, we want to be avoiding post-exertional symptom exacerbation. Everything needs to be symptom-based. It's not going to be, you know, a linear improvement. You're going to be up and down. So everything needs to be judged day to day. And then also the biggest thing would be the time frame. So this recommendation sort of says you want to be in a phase for 7 days symptom-free before you move into the next phase. Well, that's probably not going to be the case in long COVID because the symptoms just aren't going to go away within weeks. So that just needs to be discussed, and they need to have an understanding of that. So I just wanted to comment on this idea of graded exercise therapy, which you may have heard before, and it has caused some confusion about whether exercise is actually okay or not. So that, yeah, there's recent talks about, you know, how graded exercise therapy is not recommended in chronic fatigue syndrome. So the NICE guidelines have actually recently acknowledged that there was some confusion about their recommendations, and they've since updated their guidelines on management in ME/CFS to include just a definition of what graded exercise therapy is. So graded exercise therapy is a program using fixed incremental increases in physical activity or exercises. So given what we know now about we need to be symptom-based with exercises, how detrimental post-exertional symptom exacerbation can be, and what these, you know, how detrimental these crashes can be, it makes sense that we don't want a structured incremental increase of physical activity, because they're going to be different from day to day. So what they can do on Monday is not necessarily what they're going to be able to do on Wednesday. And if they're trying to reach certain targets of sets, reps, weights, they're likely going to be pushing into symptoms, and they're likely going to cause a crash. So I just wanted to identify that. I think that's handy to talk about. And I guess there's a point on this slide which says, you know, to avoid potential harms by energy management being wrongly applied to people in ME/CFS without adequate support and expertise, they do recommend referral to an occupational therapist or a physiotherapist. So that's where the role can come in. Just very quickly, this is a slide, you know, just identifying that it is still really important to have a full medical workup. This is quite often seen in the recommendations in the literature, and I think there's a lot of push for sort of cardiac impairment and a lot of focus on cardiac impairment. The research is still evolving, but yeah, that needs to be considered before we return to exercise. So just the role of the physio and exercise physiologist in long COVID. So, you know, we can talk to the patient, we can break down what they're doing throughout the week, what exercise they're doing, what physical activity they're doing, and discuss and modify that. Developing activity modification strategies and advice, working with patients to develop a symptom-based program, or to set a starting point, or to set that baseline, that conservative baseline, and then teaching them the skills to sort of self-modify and self-progress as they go, because I think that's really important. And just in red there, we can work with GPs for the more complex, more functionally impacted patients that need just that bit more support and may not be appropriate for a self-management approach. So the bottom line for exercise in fatigue management is we want to rule out serious pathology to ensure they are actually medically well, given the nature of long COVID and the unknown. The advice on physical activity and exercise needs to be individually tailored from person to person. The literature supports light aerobic exercise with cardiovascular or light resistance components and exercise in the management of fatigue. We need to set a baseline level of exercise that does not cause symptom exacerbation. Exercise should be symptom-based and titrated with a cautious and conservative approach, especially in the early days. And we need to consider pacing, prioritising, planning strategies, and ensure that they do rest as well. And just a final point, not all therapists, so if you're considering referring on to therapists in the community, not all therapists are on the same page at the moment or have the same knowledge or the knowledge on this topic. So I've had experience referring patients from post-COVID clinic to some community physios who have set them up with a deconditioning program, a graded exercise therapy program. And obviously that's caused them to crash and it's caused them to not have any improvements. So, there's been times where I've actually got on the phone with them or emailed them, linked in with them, shared resources, tried to upskill them, let them know, where we're at. And I think that's important to consider going forward is referring on. We can't just refer on and our job's done, because if this return to exercise isn't guided right, it can be to the detriment of the patients. So I'll just hand over to Sarah now, the occupational therapist.
Yes, thanks. Okay, we can all stretch, have a little move around. Okay, so we're on the home stretch, everyone. So I thought just before I talk to this slide that I'd quickly just throw in. So as we've heard about, the clinic has a huddle at the end. So I've been attending the huddle, and that's where I've been sourcing referrals from people from the clinic. So generally of the clinic, I'm getting sort of 2 to 4 people that might be appropriate for an OT follow-up. So I conduct this via telehealth. I do that for a couple of reasons. It just is simpler. People don't have that fatigue issue of having to drag themselves into the hospital, but also it acknowledges that a lot of these people are working, as we've heard. So just trying to be a little bit more flexible about linking in with some support. And as you'll hear, I guess what I'm mainly talking to people about is that fatigue management. I tend to find that people, once they've been through the clinic, have a starting or an emerging understanding, a sort of a light bulb moment, hopefully, where it's starting to make sense. And then what I can hopefully do is then help them apply it to their particular circumstances, help them brainstorm and look at their particular factors that might be influencing their energy and activity. So if we move on to the fatigue scales, it's just worth looking at these. As you heard, the modified fatigue impact scale does get used in the clinic, or people are completing it prior to coming along. So this is a 21 questions rated on a scale. The reason it may be useful, even though it's not the one highlighted in the other group of measures, is that it does have subscales that divide the fatigue into the physical, cognitive and psychosocial components. So that can sometimes be useful, help tease out where things are going more, what is causing the fatigue. So this doesn't have a cutoff score as such. It's scored from 0 to 84, with 84 being the highest score, and quite frequently people are scoring in the high 70s, and I have seen obviously 84 being maxed out the scale. The other thing that is mentioned is the fatigue severity scale. This is a bit simpler. This is a 9-question scale, which is once again applied. It's that personal response to circumstances. Also includes a visual analog scale, so people can just sort of give their rating out of 10 on their fatigue. And then the final one to talk about is that DePaul symptom questionnaire. This was actually developed for the ME/CFS population, really to try and tease out the post-exertional symptom exacerbation. It's quite exhaustive though, so just to be aware that once again can help with identifying that component rather than just a general fatigue. Okay. So what I would like to sort of suggest or talk about is that fatigue management from an OT perspective. It's really continuing that education about fatigue. The strategies that often you'll hear us talking about are the planning, prioritising and pacing. In that initial phase, which, as we've heard, can take quite some time, certainly weeks and weeks and months potentially, is that stabilising. So where we're trying to encourage people to find their baseline or their energy envelope, avoid those crashes. So when we talk about the 3 Ps, what am I talking about? Well, it's planning, it's thinking about activities that people are involved in and engaged in over a day and a week. So to enable people to set their limits before those symptoms set in. So try and identify prior to getting to that point. So what are the warning signs? That then those warning signs can then be the trigger to stop and rest. The pacing is about splitting up activities into manageable chunks, and then once again ensuring that enables some rest breaks. It's also about spreading tasks evenly over a day or over a week. The prioritising is activities that are important. That's really important that people identify what are the crucial things and what are the less important things. Sometimes less important can be delegated or left to another time. So just as I said, acknowledging that stage 1 can take some time. Patients will often have their good days, try and do more, as we've heard, which results in that exacerbation. So I think a lot of reassurance is part of this phase as well. As I said, talking about rest is important. I've sometimes found when I talk to people, okay, so tell me about your day. How do you involve your rest in your day? And it might be, oh yeah, I'm just scrolling on my phone, or I'm watching TV, or I'm, so people are still active. So sometimes even just educating people about what is rest and making sure that they understand that mental activities are all drawing on their energy as well. Just helping them to recognise the consequences that all of this does cause significant frustration and guilt. So I really see that quite a bit. People often with long COVID are, as we've heard, busy with work, with families. They're worried they're not contributing or they're pulling their weight. So just once again, trying to help them to understand the importance of these strategies to help stabilise their symptoms and their fatigue. Ultimately, what we would hope is that we get to that building phase where they can start to set those meaningful goals and very, very slowly grading their activity, as we've heard, with respect to their symptoms. I just thought I'd show you this resource. This is actually, as you can see, from the UK. So the Royal College of Occupational Therapists have produced a good, easy to understand and apply advice about conserving your energy. So it talks about those 3 Ps and then actually gives some examples where they apply it to everyday tasks. So, everything from those personal care to domestic tasks and other things. So it helps to kind of put it into action if people can apply it to those sorts of activities. Another resource that is quite useful is talking to people about symptom diaries, fatigue diaries, and activity diaries, something along those lines. This particular one that I've got on this slide can be downloaded. It's about 40 pages. It's produced by the Advanced Wellbeing Research Centre in Sheffield, Hallam University. The reason a fatigue diary is really useful is that it helps people to once again identify trends in their symptoms so that then hopefully they can self-manage and proactively plan. It can help them identify, are they having enough rest, or are there large amounts of time spent on activity with no break? It can also be useful to look at sleep. Many people with long COVID have really poor sleep and poor quality of sleep. So trying to assist by looking at sleep hygiene and making suggestions to support good rest. And as previously mentioned, it can also assist with that baseline, or what is their activity tolerance, trying to determine when it is appropriate to start adding in more activity. So hopefully this message is being reinforced over the course of this, this presentation. Just briefly, I know this is actually targeted at fatigue, but thought that it may be useful just to acknowledge the brain fog. There certainly are neurocognitive impacts that people are commonly describing. So this is some information from unpublished from Emory University, so another COVID clinic obviously overseas. What it does highlight is that memory and attention are very much the significant factors in this brain fog. From an occupational therapy perspective, I would, when I'm talking to people about this, try and help with some compensations. So that's the usual things about developing good organisation and routine. You know, if they're doing tasks, that they're limiting external, distractions, that they're using their notebooks and to-do lists, they're using their calendars, their phone alarms, and all of those common sense approaches that help to sort of manage the brain fog. But certainly acknowledging that a big part of this is that fatigue influencing their thinking. So in terms of an occupational therapy role in long COVID, hopefully you've got a flavour of it from what I've discussed. So occupational therapists can always add by doing a functional assessment to look at things like those physical and cognitive changes, doing that ongoing goal setting and review. So we're following that biopsychosocial model, doing that coaching and active listening and supporting the person. Doing the fatigue management, so that education, intervention and review. So, encouraging and educating people so that they can self-manage, they can understand their baseline, they can pace, plan and prioritise and make sure they're relaxing. That cognitive rehab to help support those cognitive functions, teaching those strategies of using memory aids and communication approaches. The sleep hygiene, and just also, which we haven't touched on greatly, is also that sort of side of vocation. As we saw from Kasani's slides, quite a number of people have had to alter their work conditions. So there are people who are now managing, reduced work hours or thinking about how they can modify their work, whether that's working at home or other strategies to manage their work. This is my marketing. I've done a website clip from the Occupational Therapy Australia website. There is a little section there where you can find an OT. And as Matt pointed out, at this stage, it's a developing area, so not all occupational therapists will necessarily feel competent or confident, I should say, with managing people with long COVID. So my best advice would be to select people, OTs with a rehabilitation and neurological interest, and then contact them to determine if they're agreeable and able to support someone with long COVID. Just to let you know that the resources that are often provided to people who attend the long COVID are at the bottom there. So they're highlighted, as well as some other resources that have been mentioned throughout the presentation here that you can see. And also another slide that once again just highlights that there are quite an array of patient resources that can be used to help support people. And references. So that brings us to the end. I will throw back to the facilitators of the presentation, if that's okay.
Thank you so much, Sarah. We so appreciate it. We have a few questions in the chat box, so we might jump straight back to you. We had a question asking, do you offer or plan to offer a home-based community OT or exercise physio service? Did you want to touch on that question at all?
And I guess our way of doing that is via telehealth at the moment. I know that there are discussions about the model of the clinic, so I'm not sure if any of my colleagues have any other comments regarding. I guess what we're anticipating is that we're seeing only a portion, and that a lot of people will be managed in the community by, referral onto private allied health.
Yeah, I guess that's sort of where we're at the moment with referrals on. When they come into the clinic and we refer on, there's a gap in what's available, particularly in the space of somewhere where you can have a multidisciplinary approach with clinicians sort of working together with someone. At the moment, in terms of community services, we refer to our day rehab service. If they come into the clinic and they're significantly functionally impacted, so they're unable to work at all, they can barely do anything around their house, they can't care for their kids. Those are the people that we really, they need that closer degree of support. So we will refer to our day rehab service. Otherwise, we use Sarah, who yes, has that telehealth approach, so that, she can contact and provide that education whilst they're at home. But then otherwise, we need to, I guess, rely on GPs and community physios, exercise physiologists and occupational therapists where needed to manage these patients. But with a lot, I think with appropriate setup and education and giving them the tools and the resources, we hope that there's going to be a large self-management component to this recovery.
Brilliant. Thanks, Matt. We had just another question just want to touch on was, do you have a cardiologist on the team regarding people with POTS or dysautonomia? Kasani, I know that you did have a referral pathway referring to cardiology. Did you want to comment any further on that?
We'd love a cardiologist. We would love it. It would be amazing, but we don't have it yet. If we do get funding, that's one of the things that we've budgeted for, is having a cardiologist session. I think it was once a month that we put in for, to be able to get patients seen quite quickly, because sometimes we really we need the patient cleared by cardiology. If they've got chest pain, shortness of breath, things like that, we need them cleared before we start really doing our rehabilitation program. So we do have a pathway through cardiology at Flinders. Sometimes patients prefer to go private. We just explore the option that's right for the patient. But yeah, we'd love a dedicated one for post-COVID, but we just don't have it yet. But we do have our pathways through.
Brilliant. Thank you so much. We've just had another question here. Can GPs use the GP management plan criteria to refer someone for some multidisciplinary intervention? So this is something our team have looked at closely, and when you look at the wording of the MBS, it states a condition that is anticipated or will persist beyond 6 months. So that's up to every GP's interpretation of that. But yes, I would anticipate that we can use our GP chronic disease management plans to access intervention like that for our patients. Any other final questions or comments from anyone else? No, it looks like we're all good. So we have gone slightly over time. So I'm going to say a really big thank you to everyone we've had on board tonight. So to Matt, to Jack, to Sarah, to Dr. Kasani, we so appreciate your time and sharing all that knowledge, the experience you've had at the PASS clinic, all those great fatigue management strategies. They're going to be really, really useful for GPs. And I know we'll be able to refer to some of those resources down the track. So we thoroughly appreciate it. The next webinar is going to be held on Monday, the 31st of October. So just a reminder, you need to register for that separately to tonight. And Professor Dennis Lau, cardiologist with an interest in dysautonomia, will be presenting, and he's expecting a lot of questions. So please bring as many questions as you can to that session. He's really prepared. And I'll be doing a short presentation on some COVID-19 complications as well. Perfect. That is everything from me. Emily, anything further from you?
No, just to echo what you said, Eve, a really big thank you to our speakers tonight. This is a really important area that we know is going to impact so many people across our communities. So we have to get this right. So we're really grateful, particularly to have your support and also the support of Salin as well for what you're offering to the community at the moment and supporting recovery through this difficult time with long COVID. So thank you. I will say as well a thank you to Adelaide PHN and to Crystal and the team who are always supporting us to be able to have these additional webinars. And we've got another webinar, as Eve said, on Monday, the 31st of October as well. So a very big thank you to Adelaide PHN, Southern Adelaide Local Health Network, to the Department for Health and Wellbeing for tonight's webinar. So thank you.